Hello and welcome to another episode of the TheSynapse e-learning program. With us today we have Professor Pierre Mallia, teacher of clinical ethics amongst other things at the University of Malta and also coordinator of bioethics research program in the medical school of the University of Malta. Thank you, Professor Pierre Mallia, for being with us here today.
Thank you.
We will be discussing with particular emphasis at the end-of-life care and also an Erasmus Plus project spearheaded by Professor Pierre Mallia, which is called EndCare and which is halfway through its course and organized by the University of Malta. Professor, on to my first question. What do we understand by end-of-life care?
Well, first of all, I would like to thank the TheSynapse for inviting me to disseminate the EndCare project and what the whole concept is all about. Well, the idea started several years ago when there was a controversy in the UK about the Liverpool care pathway. Just to put it in the historical context, in the UK many people benefit from the hospice movement and hospices, and they emphasize having a good death. We all have to die. Many people die either from a terminal illness or perhaps because of old age. Now, hospice is a charity, and so it is funded by charitable means. And therefore, in the UK, they had this problem that it was only the middle class and upper classes that were having hospices in their areas. So the government at the time decided to introduce a palliative care pathway, which was similar to the hospice pathway. And they implemented it in Liverpool, and therefore it was dubbed and subsequently named the Liverpool Care Pathway. Now, as many know, the Liverpool Care Pathway went down, in a way, the wrong path because there wasn't proper training of individuals in palliative care. So doctors who are working on the wards were expected to use this pathway in end of life. And as some of the guest speakers that we had invited in Malta said, that it became kind of a tick box, and it was criticized as being a euthanasia pathway. So we decided at the time to hold a seminar on end of life, and we invited Professor John Saunders, who was the chairman at the time of the Royal College of Physicians, who explained what the problem was. From that time onwards, the UK then sort of came out with programs to, as it were, get it right. So they tried to harmonize, as it were, end-of-life care. What do we mean by end-of-life care? And what is a good death? We all imagine scenarios where people might suffer, and how may that suffering be relieved? So we applied through the bioethics research program for an Erasmus Plus project, which is an educational project, as it were. And through this project, we tried to identify several issues that were happening in Malta. We realized that at the time there were controversies in the media about euthanasia, and some people were requesting euthanasia, so it was also an opportune time to have this project, also to disseminate. Our idea, of course, is not to discuss euthanasia, but what was lacking. And as part of the project, we started off with several studies, questionnaires mostly directed to healthcare professionals, both in primary care and in the hospital setting. And we're also now doing the same studies with nursing, with the nursing profession. And we realized that there were two main sort of hurdles in end-of-life care. Many doctors were weary about the lack of a legal framework in end-of-life. So we all know the moral principles in end-of-life care. You don't need to give futile treatment. You don't need to give extraordinary care. Patients don't need to accept extraordinary care. In fact, patients even have a right to refuse treatment. And especially when it comes to the terminal stages, you can give as much pain relief as is necessary, even if this hastens death. Of course, there were a lot of confusion, both amongst professions and, as it were, in the public. So I participated also on some radio programs, and people who called in were saying, it was that last dose of morphine which killed my mother. And therefore the relatives felt that this was a form of killing, and perhaps it was confused with euthanasia. When we saw the vox pops that were occurring on the media, on programs at the time, where we were invited as well, many people who were answering yes to euthanasia and were asked why, said, well, why ought you to die in pain? Why cannot I refuse certain treatment? So it struck us that the reasons people were giving were not actually good reasons to support an argument for euthanasia. The reasons were reasons which ought to be carried out already. So we were asking ourselves, why is it that perhaps end-of-life care is not being given in a proper way? We have very competent doctors, we have good hospitals, but what happens is that we don't have a proper structure, both within the hospital and outside. And when I say outside, I mean the legal framework and perhaps even the social institutions who may be teaching more on the negative side, as it were, sort of you ought not to have euthanasia, you ought not to kill patients, and not imparting proper information of what you actually can do. And therefore the project, which is called Harmonisation of End-of-Life Care, actually means that trying to define a curriculum to create workshops or retreats for health professions, and hopefully we'll get another project which will then involve patients, but we wanted to understand the problem inside, in-house as it were, and see what are the limiting factors. We found both interprofessional and interprofessional issues, but the main two problems that came out, and one can read about these on two articles which were published by myself and Dr. Jürgen Abela on the Maltese Medical Journal, and one on the Journal of the Malta College of Family Doctors. The main reasons were concern about a lack of legal framework. If I am a doctor and I discuss with the patient that this treatment is basically futile and we need not give it, there is this sense of fear that if I remove that treatment, the relatives might sort of seek recourse to the courts. And in fact, this has happened. It has often happened that a doctor makes a decision with which relatives might not be that comfortable with. We need not go into that. But in reality, people come from abroad and they perform their medical treatment at the end of life as they had been doing in other hospitals abroad. Whereas in Malta, we did not have a proper pathway on how patients can be transferred from a curative pathway to a more caring, palliative pathway.
And in fact, I wanted to emphasize the fact that this interview is being produced right at this time, at the opportune moment when discussion is underway between both the medical profession and also society in general on how to best regard end-of-life care. So the main challenges which are here locally affecting end-of-life care, you say, are the legal framework, possibly, which needs to be developed, and also misinformation.
Yes.
How is the project which you are spearheading thinking of tackling these issues?
Well, the project is now already halfway through. It's a 3-year project. We were funded through the EU. We originally planned to have 4 partners. 2 of them did not send in the application in time, but they are still on board as experts. So as partners we have the City University of Dublin and the University of L'Aquila in Italy. And we also have experts therefore from the UK and from France. From the UK in particular, we can learn from their experience because they had already created a pathway, and it's not good enough to form a structure on end of life and then not implement it in the right way. This was the experience of the UK. So we thought having the UK on board was very important for us, so as not to repeat mistakes, as it were. We also thought it important to have various bodies on board. So we have representatives from UNESCO, we have the Chancellor of the Pontifical Academy for Life of the Vatican, but we also have people coming from the Muslim community, we have a professor from Iran, and we also have other experts coming from other countries like Belgium and several others.
And why do you see that Malta has such an important role in this discussion? I understand that on a regional level, we need to make sure that the end-of-life care here in Malta is appropriate to our own culture. Yes.
I think the project clearly states it is not here to sort of reinvent the wheel. We are not trying to either discuss the concept of euthanasia, neither are we trying to say the moral issues should be this and that. The moral issues are there, they are written down. Yes, you're quite right. In Malta we do have a kind of normative value. Mostly it is Christian. I would like to qualify that in a moment. I would say most people would recognize the teaching of the Catholic Church, but the problem is they do not know what actually the Catholic Church is saying. So the Catholic Church actually says you do not need to give futile treatment at the end of life. A patient can decide what is ordinary for him or her and what is extraordinary treatment. And it is the patient who decides that. It is not the doctor who decides sort of, I think this is extraordinary for this patient. Sort of the patient has always to be informed. Also, you can give as much pain relief as is necessary. It has been shown, actually studies have shown that following a proper standard of care, pain relief does not shorten life. But the moral principle states that even if it shortens, it hastens death, it is still morally just. It follows the principle of double effect, that it is a foreseen harm, but it is unintended because your intention is to relieve the pain. So that is not really the problem. The problem is that this education, as it were, is not really disseminated. So we did get other faculties on board, which are the faculty of law and the faculty of theology. And in fact, just this week we have finalized a consensus statement about these principles. We have spoken to the Medical Council, we've spoken at the Parliamentary Social Affairs Committee when there was the debate on euthanasia going on. And our aim is to harmonize end-of-life care in Malta, both in secondary care and in primary care. And we are not there to sort of dictate what ought to happen. We are getting people together to see and analyze what the problems are. So there is this, following the Roger Neighbor, sort of the inner apprentice, we have to discover what is the agenda of each and every healthcare professional, what is their inner curriculum, what do they feel are the limits, why are we not providing end-of-life care as it should be. So the solution is found through this sort of adult group discussion. And from there, then, we have to create the necessary medical, political, and social pathways in order to better end-of-life care. Going through a project means involving a lot of time and energy, and the worst thing for me as an academic would be to go through the 3 years of the project, have good academic publications, but at the end of the day it is all shelved over there and nothing good comes out of it. I think our goal is really to help improve the situation. Everyone feels that it needs to be improved. And the fact is, you do see patients or relatives who have had patients pass away who say, well, unfortunately, they died in pain. Or, for example, they continued to give treatment till the very end. And I am sure that if today you go into the main hospital and you ask how many people died, and they tell you X people died today, and you go and ask the head nurse, did they have a drip attached to them when they passed away? I am sure that 99.9% of those patients would have had a drip, because we have this sort of concept that if we don't put a drip, the patients would die dehydrated. Mm-hmm. Now, there is a lot of debate going on that, but it is not true. Dying patients do not naturally die with a drip attached to them. In fact, that drip can cause a lot of discomfort. Many of those patients would have had that drip replaced within the last 48 hours. To replace a drip of someone who's dying, you have collapsed veins, you have to jab them a number of times, and that causes unnecessary discomfort to a dying patient. So we need to have the courage, but also the legal framework and the social understanding from the parts of patients and the relatives that this is something which ought to be done. We need not have someone dying with a nasogastric tube going into them, with pipes coming in and out of the body, with a drip. The drip, is going to cause someone to want to relieve themselves from the fluid going into the body. It can also cause harm. I'm not saying that is what is being done, but it is a possibility. So we need to come to a point where we recognize that. And this is becoming important. And in fact, it's also written down in the guidelines issued by the UK General Medical Council, that the recognition of the imminence of death is important.
Now, thus increasing the significance of the ceiling of treatment in the end.
Yes. Now, what is the imminence of death? Of course, if I'm going to die within a year, well, death is imminent. And so it is important at that stage to start discussing with patients. And we're now not speaking so much of advanced directives, but we're speaking of planning, an advanced care plan. What would you like to do? And what are your goals? What are your accomplishments? Would you like us to continue giving you treatment till the very end, or would you prefer just being comfortable? At the end of the day, we know that a lot of treatment is futile. We're giving it for nothing, just to sort of satisfy our conscience, as it were, or because there is no framework which gives us a safe environment where we can do what is proper.
I also believe that in our cultural background, sometimes these discussions are not always as patient-centered as they should be, with relatives maybe putting their emphasis on the patient's care without the patient even voicing his or her opinion.
I think that is not really the fault of healthcare professions, be it nurses and doctors. That is probably the fault of a lack of a framework. And this is what this curriculum is about. The curriculum is about harmonizing end-of-life care. It's about seeing what structures need to be done and what political pathways we have to go through. And I say political, I'm not referring to Parliament, although that is important because in Parliament they do amend the laws and we have already given some recommendations, but also the political environment within the hospital and the political environment within the religious groups. I said I wanted to qualify the religion. We did also a survey and we compared religions, the Islamic religions, Christian religions and Judaic religions, and in fact they all agree on end-of-life care. They all agree you do not need to give futile treatment, that patients have a right to refuse extraordinary care. What is important is that we need to plan with patients. Some people would want some type of care, other people would prefer to refuse. So for example, if someone can have his life prolonged with a ventilator, perhaps even by several months, but that patient also has a right to refuse that form of care because that patient might feel it is extraordinary, and therefore there ought to be this right to refuse this life-prolonging treatment.
Professor, thank you for your time. We hope that through this interview we have managed to disseminate more the impact that this project will hopefully have in the Maltese local community, and we invite our audience to share this video with their professional colleagues. Thank you.